how is one individual different than another? I mean, there's certainly a difference between a Great Dane and a Chihuahua, even if they're the same age. But there are differences between a 10-year-old Labrador and another 10-year-old Labrador, even if they look the same. And that's what we're heading towards and starting to get into. What's difference in their metabolism? What's difference in their microbiome? What's difference in the way they handle a nutrient? Is the nutrient in this dog the same that the other dog should get? I mean, things like that. Is really interesting because, again, it individualizes the care, not only treatment, but preventative. And at the same time, it's a holistic approach to the individual, not just the population.
This is Pet Food Science Podcast, and I'm here with Dr. Joe Bartges, who I'm very pleased to be with, and it's an honor and a pleasure. As Joe knows, we just were chatting about it. The reality is, here we are. We have a chance to talk about pet food science with Dr. Bartges, who is an expert in a number of areas. And Dr. Bartges, if you would, could you tell us your background?
So given my age, hopefully I'll remember it all. But I am from West Virginia originally, born, bred, and raised in Charleston. I went to Marshall University, graduated there with my bachelor's of science. And I then went to the University of Georgia, where I graduated in 1987 with my Doctor of Veterinary Medicine degree. After that, I went to the University of Minnesota, where I completed an internship and stayed for residencies in small animal internal medicine and nutrition. I did a PhD as well concurrently. I then stayed for additional time to do a postdoc fellowship. And then I joined the faculty at the University of Georgia. I was at Georgia for about a little bit over 3 years, from 94 to 97. I then went to the University of Tennessee. I was on faculty there until around 2013. While there, I held an endowed chair of research, and then I was interim department head for about 4 years, so it wasn't so interim. I then left and went to Cornell University Veterinary Specialist, which is a referral practice affiliated with Cornell University in Connecticut, and also had a position at Cornell University. And then in 2016, I came back to the University of Georgia, 3 times the charm. So this is my third time here. And my third time here, currently, I am a professor of small animal internal medicine, interventional radiology, and nutrition. I also am the Bulldog veterinary medicine professor, and this is probably my last move. So when I retire, it'll be from here.
Well, that's
so go
good.
Dogs.
I always, you know probably that I also am a graduate of the University of Georgia, and I remember those days fondly. It was a great place for an education.
Yeah, it's a good place for an education, and very good place for sports right now, at least the football.
Yes, well, it was good when I was there too. There might be a connection.
That's true. I came shortly after the 80 championship, but the last couple of years have been really good.
Well, that's good fun.
Tired of one-size-fits-all solutions that don't quite fit? At Wilbur Ellis, we're bringing custom back to the customer. We know that for your pet food and treats to shine on the shelf, you need to start with the best. After all, even the best recipe is only as good as its ingredients. From nutrition to preservation to blending and bottling, make one call to Wilbur Ellis Nutrition to find it all. We don't sell to you, we work with you. A true partnership to meet your needs. Follow Wilbur Ellis Nutrition on LinkedIn to learn how partnering with a purpose could double the power of your team.
Your expertise covers a lot, and we have a great deal, to kind of pull into this episode. We won't get it all. Maybe we'll talk more than once. But I thought we might start with arthritis, and just if you could, tell me what you've seen as, a nutritionist and as a veterinary medicine practitioner with arthritis in dogs and cats. And of course, we're going to talk about the science of feeding those. So let's start with the background, if you would, please.
Sure. Well, osteoarthritis is certainly a well-known problem of dogs in particular, but it also occurs very commonly in cats, and some estimates are over 90% of cats that are older, maybe than 10 or 12 years of age, have some degree of osteoarthritis. I think the issue is that many cat owners don't recognize it. Some cats are really good about hiding things. They don't show the obvious lamenesses, holding legs up and things like that. What it's interpreted as is that they're older, and so they're just not as active, and so they sleep, and they don't want to go up and down chairs or jump on and off the bed or anything like that. And it can oftentimes be related to osteoarthritis. And so my interest in it actually was sort of by accident. When I came to the University of Georgia in '94, I started getting involved with some research with fish oil and things like that, and then looking at different things. And I went to a human conference. They were talking about fish oils and osteoarthritis, and the dosages were wrong and everything. And it sort of struck me that a lot of the things in human medicine, but also in veterinary medicine, certainly in the 90s, were more related to being reactive than proactive. You know, like you don't do anything until something occurs, and then you try and make it better or reverse it, which by then reversing is usually not even an option. So I came back, and one of our orthopedic surgeons who had started a couple years before me, Dr. Steve Budsberg, I went to him and I said, I got this idea. What happens if we feed fish oil before they develop osteoarthritis? Like, we use it for the inflammation, but what happens if you did it beforehand and then you used it while, when they had it? And he said, oh, nobody dismissed me. And then about 2 weeks later, he came back and said, so I got funding to do this study. And so we did this study with dogs who had induced arthritis of the knee, a cruciate ligament.
Yeah, no, I remember that study.
And we developed diets that were high in omega-6s, that had a sort of amount of omega-6s that you would like some of them don't have any fish oil in it, but a 30-to-1 ratio, 6-to-3. And then another diet sort of in the middle of about 8-to-1. And then another diet that was 1-to-1 omega-6s to omega-3s. We thought, well, we'll do an efficacy and safety study. So we fed them the diet, a standard diet. We did joint taps and things like that. Did force plate analysis, looking at how well they walked. Broke them into 3 groups, fed them for a time, induced the model, and then followed them along. And it turned out that the dogs who were fed the 1-to-1 fish oil to omega-6 to omega-3, the high fish oil diet, and the diets were totally the same otherwise, had less inflammation of the joint, had less joint changes on radiographs, had better walking ability, we could demonstrate that the fish oil got, the omega-3 fatty acids got incorporated into the joint membranes. And then we went back and we fixed them like you would do for a patient. And so he went back and fixed their cruciates, and then you couldn't tell the difference between the groups. Clinically, they were almost exactly the same, except as we followed those dogs for a period of time, the dogs continued on the high fish oil diet had less and very minimal osteoarthritic changes on radiographs, and their ability to bear weight was better than the dogs on the other 2 diets who had progressive changes. So after that, my interest, in looking at osteoarthritis expanded into the role of obesity and how do you modify the inflammation and doing those kind of things. So I think it's a really good example of not only can diets help when the disease is present, but that it can actually intervene by preventing some of the disease before it even happens in high risk, dogs in high risk situations. Something to the effect of what Thomas Edison, to paraphrase Thomas Edison, said, which was, in the future, nutrition is going to be the medicine that doctors use, or something along those lines. So that's where it all began. And it's something that about and those fish oils became incorporated into therapeutic diets, but we now often use therapeutic diets designed to treat patients with a certain disease before they even have it in high risk situations as a means of preventative rather than as intervention.
No, that's a fantastic story and really a story about I think in oftentimes, fixing a problem, what you said about fixing a problem being perhaps a harder thing to do than preventing the problem. So if you can get in there with this high omega-3 food, you're likely to reduce the incidence of these arthritic problems. Then is what I hear you say, which is just fantastic for nutrition, isn't it? It's just the food is your medicine right up front.
Yeah, it sort of is a similar idea of the work done, I don't know when it was, 80s, 70s, that Herman, Haselwinkel, and others did looking at calcium and developmental orthopedic disease, and that you can take breeds that have the genes to develop orthopedic disease and modify it, the phenotype, their outcome, how they look, by changing their diet. And I think it's something that we don't think about very often. Unfortunately, veterinarians, some of the surveys even, veterinarians think of preventative as heartworm disease and vaccinations and, things like that. Whereas clients, a majority think of it as, am I feeding the right diet? Can diet help prevent something from occurring? It's more the environment, not so much the medicine part of it. And I feel that it's getting better, but I think there are a lot of veterinarians that don't think along those lines. Like, what is the role of nutrition before the problem occurs, and don't realize the impact that it can have. It's not going to help everyone. But on the other hand, if you own the dog who has the risk and you make a change and that risk is minimized, it's 100% for your
and
family member.
You sort of think of it as we do so many things with our pets to control their environment. We don't let them play in an unsafe area. We do, but maybe the biggest environmental thing we could do is what they're eating, and that's a huge component.
Absolutely. And unfortunately, again, I was going to say, a lot of people just think, well, you just open a bag or pop a can and that's that. And they don't think about what they're feeding. Even the best of diets given to the wrong pet doesn't get the benefit that you want. We think of more in the terms of the worst diets to even the best of pets causes problems, but you've got to pick and choose what fits the situation.
Yeah, that's great advice. You touched on obesity, and you and I have talked about that over the years a bit, but its interaction with arthritis and certainly another food responsive endocrinology, if you will. You want to just talk a little bit about obesity?
Sure.
I love hearing what your thoughts are.
Yeah, again, it's one of those funny things as we started working on stuff. And that was when people started coming out with surveys of dogs, 40% were overweight, 20% or 12% or something like that were morbidly obese. And, some of the pet champ data, things like that Liz Lund generated. But we started looking at it at the time back in the 80s, 90s. It was, it was a mechanical issue. You have too much weight. It puts too much forces on the joints. It causes arthritis. It's just a cycle that, no pun intended, but keeps feeding on itself. You're obese, you have a joint instability, it makes it more unstable, so you become more obese, right? Yeah, sorry, I couldn't help. I guess pun intended, actually. But around that time is when people started coming out with the notion that obesity was much more than just a weight issue, that it wasn't a mass effect, that it was an endocrine organ, that it changed metabolism, that you could change bacteria, and you can change the bacteria in your gut and change your obesity, with the rat studies that they did back then. And so you start looking, and now the mantra that, nutritionists usually teach students in veterinary schools is obesity is an inflammatory disease, which is true. It's a pro-inflammatory state, but it's more than just sort of just the obesity, the mass effect. The effect of that inflammation is systemic. So you get obesity associated diseases that are inflammatory in nature: osteoarthritis, pancreatitis, dermatitis, and enteritis. I mean, the itises or whatever, just go on and on. And so we started looking at some of that as well in terms of, as many other people have done way more than I have, but we started getting interested in that as well. And we did a study looking at obese cats, and at the time a lipidosis, where they don't eat, they mobilize their fat from their external, subcutaneous, it goes to the liver and they go into liver failure. back in the 80s, early 90s, it was almost uniformly fatal until you learned to intervene nutritionally. And it's interesting. It very much mimics anorexia nervosa and bulimia in that when they're obese, they have these inflammatory mediators that are upregulated. And then they also have mediators that shut off appetite. So, for example, tumor necrosis factor, which decreases appetite, are very high in fat tissue in obese cats. And you think then if they stop eating, they start mobilizing their fat, they mobilize all these tissues too. So now cats don't want to eat because you'd think they'd want to eat since they were fat to begin with, but they don't want to eat because they've got all these hormonal changes. So, I mean, it's just things like that where you take advantage of situations and you just, you keep up with literature, you listen to what people say, and you start thinking, well, what if we did the following? What if we, changed, something else? We've got some studies going on now looking at, we've done body composition studies where you can do something called dual energy X-ray absorptiometry, or DEXA, which is a non-invasive way. We just have a new DEXA scan at the University of Georgia. It can do a whole dog scan in like 2 minutes. It's amazing. It was a donation from a client, bought the unit, got 5 years worth of
use,
taking care of it. And so, we've started using it for different things. One of the things we're looking at is, and it will differentiate intra-abdominal fat from peripheral fat too, with the way you draw your regions. It's really cool. But, we've got studies that we're getting ready to do and have started looking at different foods and how they change where the fat's deposited. Animals with osteoarthritis, what's their obesity? Some of them don't seem obese, and then when you scan them, they've got a lot of intra-abdominal fat. They talk about the pear versus the apple in humans, things like that. So it's interesting in the fact that we have more tools available than we had 30 years ago. Really start looking at the nuances of some of the things, and I think that's where pet nutrition is. A lot of the big things have been addressed. Total deficiency, toxicities, things like that. And now we're getting to the point of how do we make it better? It's good, but can we do better? Yeah.
Yes. Excellent, Todd. And aren't we getting more into this? Balance is too easy of a term, but in a sense, the multifactorial component of nutrition, so that you are thinking more broadly than, when we first came in and said, well, we want to meet all the minimums, not go over all the maximums, and you got a pet food. But it's more than that, isn't it?
Yeah, it's much more than that, because it's not only like you have too much or too little, but what is having just enough or just barely under or even a normal amount, what does that do to everything else? Because if it were so simple that it's too much or too little, then we would cure everything, because all we do is just give enough. And yet we know that diseases occur when you have enough. And so the question is it enough for the situation and for the pet? So the kind of the new terminology now is, One Health medicine was sort of the buzz term 10, 15 years ago. Now it's precision medicine. How is one individual different than another? I mean, there's certainly a difference between a Great Dane and a Chihuahua, even if they're the same age, but there are differences between a 10-year-old Labrador and another 10-year-old Labrador, even if they look the same. And that's what we're heading towards and starting to get into. What's difference in their metabolism? What's difference in their microbiome? What's difference in the way they handle a nutrient? Is the nutrient in this dog the same that the other dog should get? I mean, things like that. Is really interesting because, again, it individualizes the care, not only treatment, but preventative. And at the same time, it's a holistic approach to the individual, not just a population. The
very best for that pet. And how do you think, this is a little bit of a sidetrack, but how do you think we get that? I mean, I like your 10-year-old lab, but the two might be very different in lifestyles, if you will, or something. But how do we get to that understanding, do you think?
Yeah, if I had the answer to that, I'd be here as a Nobel Prize laureate, not as a aging faculty member. I think, again, what we're getting to is the capability of technology. I mean, the idea that it's not, I don't know, these are going to be poor examples. And I appreciate you letting me ramble, because as you get older, you ramble a lot anyway. That's the students that I teach.
Too, so.
No, or just a lack of capability of stopping yourself. I think that the omics are going to lead the way. They're starting to lead the way. Like, what, it isn't just, is this a 10-year-old lab and that a 10-year-old lab or whatever it is this a 10-year-old lab and what's metabolism? Well, how do you check that? Well, things like metabolomics, for example, tell you to some degree, here's what their metabolism is that's going on. Here's what the proteomics, here's what's going on. I mean, the genome part is interesting because it shows you the genetic risk, but genetic risk, unless it is just a straight out genetic trait, some mutation that results in something like Down syndrome or whatever, those genetics are being modified by everything else.
Well, your calcium in large
what they eat, the environment they're in. Yeah. What they eat, how they exercise, how much do they exercise, are they exposed to different things? The epigenetic part of it is very interesting. And we're getting to a point now where we're looking at, we're not only looking at that, but we have started looking into things that are called microRNAs. So we're not even just looking at RNA, we're like little pieces and stuff. And I think that you just keep getting smaller and smaller, you get more details. Then what's got to happen is it's got to become accessible and affordable. Otherwise, it's great that you can do all this, but if it takes $1 million to test your pet, very few people are going to be able to do it. But as the technology advances, it will become more and more. I mean, it used to be you do like a whole genome study, and it was thousands of dollars. Now it's only you can do it on campus for like $100. Yeah.
That's fascinating, and thank you. One of the things that I've looked at and we've done.
I'm sorry to interrupt. I would say one more thing. The other thing that has to happen is because it's becoming so specialized, people who are doing this are narrowed into their field, right? They are not only like a person metabolomics, they only look at metabolomics in diabetic people, or something like that. And what it takes is someone who's more of a generalist to take a step back and say, how does that impact everything else? Right? Because you're getting all this information at just this great detail, and they see not only the tree, they see the leaf on the tree, but they don't see the whole forest as to how does that interact. And that's where veterinarians come into play, because we're much more holistic than physicians, I believe. It takes clinicians with basic scientists, because the basic scientists understand that, subcellular stuff, but the clinician says, well, how does that help a dog or a person or a child or a whatever? And it's got to take that integration of everybody to really make this, to bear the fruits.
Tremendous truth there. And I actually want to get back to that before we're done and just talk to you about how you see building those successes in a team. Let's set it aside for a moment. I wondered if you might talk about the stone risk things that, we've done a bit and aligned with each other, but you've done a lot of work looking at those stone formers in dogs and cats. And, you're just, again, if you tell us what do you see there? What's the foundation you're building on, and then maybe what you might try and do nutritionally?
Well, I think, there was sort of a flurry in the 80s, 90s or so, and then a lot of diets came out to help, and they're based on science, good science. But I sort of went away from it for a while, and I've come back to it because it is an example of an inborn error of metabolism. I mean, not in the strictest sense, in terms of things. Some stones are like cysteine or urate, but it's why do some pets get stones and others don't, given the same situation? And so what separates them? And again, I think it's something that shows that diet can not only treat it in many situations, not all, but can help prevent it, and prevent it in ways that high risk individual pets, dogs, cats, can benefit from not having to go through having a stone before someone says, well, maybe we got to change your diet, or to give you a drug or a combination thereof. So I've come back to, we're doing some studies clinically looking at things. We're starting to look at again, the metabolism that the pets have, changes in metabolomic profiles. We're starting to look at, there's some evidence of microRNA, what roles that may have in different situations. But it just shows that a stone formation isn't just they're dumping a bunch of minerals in urine and they just form a stone, that there's a lot more that goes into it. And while diets certainly help that a lot, the question is, what can we do to make it better? Because the ultimate treatment isn't to be able to do something non or minimally invasive to treat pets with stones. The goal at some point, probably not in my life, is to say, here's the ones that are high risk, and if we intervene now, they'll never form a stone. So they don't have to experience the treatment.
Yeah, fantastic goal.
But yeah, it's very interesting. The saturation studies, the role of different ingredients, the inhibitors that are present. How can we help? Are things that I've cycled back to in the last year or two.
A little bit for me and for the folks listening. You've been there a lot. What would you look for in a food to aid in that management, to try and prevent, or number of foods have been shown to reduce the reoccurrence? What would you look for as your expertise over it?
I think what we're starting to look at more now isn't you're changing. So when we look at stone disease, one of the things that's often used is looking at the state of saturation. So they call it relative supersaturation, and there's different ways of doing it. There's computer programs that do it. There are different types of computer programs that do it, and even different pet food companies use the different computer programs. And you do get different answers. So like there's no one test that gives you that. But it's more than just that. It's certainly part of it. And saturation just basically says, if I'm at risk for a certain type of stones that's composed of some minerals, and what's most common in people and over 40% of dogs and cats is calcium oxalate. So if I have a urine that has a lot of calcium and oxalate in it, then my saturations are high and I could form a stone. The trick is that a lot of humans and a lot of middle-aged to older dogs and cats have urine that's saturated with calcium oxalate, and yet many don't form stones. So there's something that separates them. And the question then is what separates them, and it has to do with these inhibitors and things like that are present in our urine. So when I look at diets, it isn't just, does it modify the concentration of minerals, but is there something that changes, that the diet can do to change the risk of them forming stones, even if it doesn't change the minerals that much? And if you can change the minerals and have that, then you've got a double-edged effect. And that's what I would look for. Things that are known to inhibit, like citrate, for example, is one that helps with calcium oxalate. Mm-hmm. Some studies show they don't, but if you look closely, they usually do. And so things that increase that, things that dilute out the urine, dilution's the solution to pollution, things that help lower the mineral levels. But even if you don't get them down low enough, can you change the environment in the urine to prevent those minerals from coming together and precipitating out? Either they pee it out more often, or you've got something to keep the minerals from binding. So those are some of the things that we're looking at as well. And I think the other is there's still there's still a metabolism problem. Like not all miniature schnauzers form calcium oxalate, but that's a high risk breed. So what separates the stone formers from the non-stone formers? What's different about them? Genetically is one thing, and it's probably harder to find, but metabolically what's different. And if I change diet, can I change their metabolism, right? I mean, that's really what you really want to look at. It's not the end. It's what do you do in the middle that changes the end, not how do you change only the end? Which
kind of brings me to fatty acids back again. And it's sort of an inflammatory disease. What do you think it's just reduce the inflammation as we know how with arthritis, or is there more there than that, or what's your view?
Well, I think there's part of it in there, and it's certainly true. With stone disease in people, probably more is what we know about than actually dogs and cats. Now, people, we usually form kidney stones, and our kidney stones are often calcium oxalate. And it's been shown that people form the crystals inside the kidney tissue first, and there's inflammation, and then those crystals sort of migrate into the urine space. and then form the stones in the kidneys. And so there have been studies. There was a researcher at the University of Florida, medical doctor, physician, that looked at fatty acids and published a lot on fatty acids and their role in stone formation. Because those fats get in the cells and the cell membranes, you get inflammation. It changes the composition of urine to a degree, and it changes metabolism, right? You shift from energy coming from one nutrient to a different one. It hasn't been looked at as much in dogs and cats, although I usually do use it. I mean, the presence of stones causes inflammation, but inflammation could be part of the stone formation because stones are not just minerals. They're 95% mineral, but there's about 5 to 7% that's something called matrix, which is this proteinaceous junk, the sort of like toothpaste cement that holds everything together. And in a very organized fashion. And it's hard to evaluate what that matrix is composed of, but what they have found in rodent models and in humans at least is that it's composed of inhibitors of crystalline stone formation, but also inflammatory proteins and proteins that leak from the cells in the kidney. And so that's where things like fish oil and changing the inflammation and changing the metabolism so you get different proteins might have a role.
Yeah. Well, that's great. Which, I'm enjoying our talk. I wonder if we have a little bit of time, short time, because I do want to get to team dynamics, but a little bit about kidney disease, where you've had a lot of research and a lot of interaction, I'm sure, as a veterinarian. So let's do the run on kidney disease.
Well, kidney disease is again, we're finding more and more that it isn't just you end up with it and so be it. So there are things, again, that we're starting to recognize that can make it worse. We know from diet alone, we can slow it down in many situations. It is still a chronic kidney disease. It's still a progressive disease, but we can slow the progression down. Dogs in some studies live 3 times longer on a therapeutic kidney diet than if they don't have their diet changed. Things like that. And again, it's coming down to, at the time, we just sort of didn't know, because these were studies that were done 10, 20, 30 years ago. We know different nutrients have an effect, but we didn't know why. And now we're starting to figure out the whys. We know the role of hypertension and protein loss in the urine, and now we know diet can modify that, some of those things. Again, we're doing some studies, and one of our surgeons has done some studies with microRNA and its role, because different types of microRNA are associated with laying down scar tissue and inflammation, and you can change the microRNA by diets in some situations. So we're starting to get down to the nitty gritty, the details, to figure out why it works in some and why it doesn't work in others, right? I mean, even if you have a treatment, no treatment is 100% for the most part. And so the question is, why isn't it? But again, even more so, how do we predict which ones would, and can we intervene to prevent it from happening? That's the long-term goal.
Well, that's great information. And really, part of that why is really understanding the health, right? So we've always sort of had the mantra that, well, we see when things go wrong, but understanding why they're going right is a lot harder.
Well, I think we're starting to, at least some people, but I think we have failed to realize that it's okay to have a disease. The question isn't reversing the disease. The question is living well with the disease, right? Like, you have a chronic disease, it's not going away. You're controlling it. And so as long as you don't have problems with the treatment, how do you live well with the disease? There was a study looking at Rottweilers, and it was from birth to death, basically. And so many of them, there are quite a few still alive in it, but as the Rottweilers aged, they found that a lot of them had cancer. And they didn't die of cancer. They weren't even diagnosed with cancer. But when they did the autopsies, they found that there was a reasonable percentage that had cancer of some sort, not just benign cancer, but malignant cancers. And you go, well, what made them, why didn't they show problems? Well, they somehow, their metabolism, whatever it is, they learned to live well with it. And they ended up dying of something else, not the malignant cancer that they lived with for who knows how long.
It's fascinating. We've seen a little bit of that with calcium oxalate stones formation. That cat looks completely wonderfully normal, has a normal life, and then we find you
take a radiograph and suddenly you find all these stones you didn't even know they had because they hadn't have any clinical signs. Well, I mean, that under low-grade liver disease, chronic pancreatitis, heart, low-grade heart disease, for lack of a better term. Just things where you go, well, they're abnormal. As we get better at diagnosing things, we're now finding things that we didn't see before because our ultrasounds are better, our blood work's better, things like that. And then you go, but they're totally healthy. Like clinically, they're fine. Which is worse, not treating what I have found as abnormal, or perhaps giving them a treatment that will make them sick when they weren't having any problems to begin with. So we're sort of stuck right now in this conundrum when we find these things. I found this mass. Now what? Because there's a 16-year-old dog and they're clinically fine. They're here because they need a dental disease, and I find this liver mass. Now, do I take them do I take a 95-year-old person without any clinical signs to surgery, basically, if they're a 16-year-old dog?
Yeah.
For some people, they'll want to do it. And for others, you feel like you should do it. And you have to sit down and say, if this were your 95-year-old mother and she was totally fine, no problems, would you want her to go under anesthesia and an open surgery? And that's we're hitting that point because we don't know what to do with them yet. We don't know what happens if we don't do something.
Mm-hmm. No, that's great. Dr. Bartges, you had talked earlier about, this value of having someone around you who complements your expertise. And it fascinates me, as I've been in this sort of scientific endeavor a long time, and that value of the successful team. First of all, it's just fun. I always love it because it's fun. But then putting it together and holding it together, what do you see? What would you look for that team you wanted to be involved with, or leading and members you wanted to bring in? What characteristics might come to mind?
Well, I'll start with the general idea first, and I'll get to a more specific thing. So the general idea is to find people who are excited and interested in advancing knowledge about something, whatever that something is. And it takes an understanding that everyone has a role. Some roles are going to be maybe bigger than others, depending on what you're doing. As a clinician, I don't have a $2 million, $5 million lab with all this equipment. I have to find people who can do it. And so if we're doing stuff where we're using the equipment, then they have a big role in this. And I am the one who's just trying to oversee things. So it takes that. It takes a willingness for everybody to share. My mentor as a resident was Dr. Carl Osborne, and one of his sayings was, "Art is I and science is we." And it takes that we approach. And unfortunately, there's enough islands in medicine and veterinary medicine that they don't all come together, versus, the team community approach. And sometimes you lose out because you're trying to work with somebody who has 4 NIH grants and $20 million of funding, and you've got this little $15,000 study. To them is sort of not necessarily important, but because it's not important to them and their career and their postdocs and everything else, even though that may be your whole career, pretty much in a small dollar nutshell. So it really takes a willingness to do it, and it takes an environment where it's encouraged. Now, having said that, I've been at a couple of schools, and it's gotten better through the years, I will say, and this is perhaps a shameless plug for the University of Georgia. It's really good here. I've been here 6 years, and I work with a metabolomics international, eminent scholar, metabolomics expert. He's in Complex Carbohydrate Research Center, with someone who does mass spec and chromatography. We work with some folks who are researchers at Virginia Commonwealth University as part of our group. People within the department, people within the college, outside the department. Where I've worked with people at Emory University, and one of the things that the University of Georgia has pushed from our provost is a precision medicine approach, and is very specifically geared to hiring people who do sort of communal work. You are there to help other people. So we have one person who joined us from Iowa State, Karen Allensbach, who's a GI expert, a veterinarian, and she's doing organoid research. And we've already started collaborating. Not only we, but we as the department have already started collaborating with her with clinical studies and things. I mean, that is what you need. You need someone who says, I can do the techniques, but I don't have access to the natural, spontaneously occurring disease. You've got those, and we'll learn from that to the translational part to humans, but it will benefit your pets, your patients, which are dogs and cats or horses or whatever, you're working with in terms of being a veterinarian. That is the attitude that has been fostered, and one of the reasons I don't see me leaving here except to retirement, because there's so much fun stuff happening.
I mean, that's just the thing that gets you up, right? It is fun and it's exciting, and I always smile because the team, the benefit, the sum of those is successfully is so much greater than the individual parts contribute, and it's a marvelous thing.
Yeah, absolutely. It is more than the sum of its parts.
Yeah, it's great fun. Well, what do you think then? Are you, if you look over the horizon, you see anything that you might want to tell? Maybe not your next grant proposal, because you might want to keep that, but what sort of things you might. Yeah,
well, we've got things. So we're still we're still doing stuff with stone disease, with collaborating with folks looking at cancer, lymphoma in particular. We're doing the chronic kidney disease studies, and primarily cats, looking at different things. Body composition studies and interventions, not only from obesity, but body composition in different disease states, things like that. One of the things that's exciting, all of them are exciting, but one of the things that we've gotten involved with in the last COVID sort of put a damper on it for a little bit, but 5 years or so is the role of how food is processed and health and disease. So we started looking at, in human nutrition, they talk about ultra processed, and minimally processed foods. So we started looking at how food is processed, pet foods are processed, and does it influence different things? So I have one doctoral student who finished. I've got 3 doctoral students right now. 2 are mine. One is in bioinformatics. So I'm on her committee, but we're looking at, dogs. We're doing some studies in cats too, where we're feeding them. We're to the point now where we can make identical diet, it's a misnomer because you can't do this, literally, but identical diets that are just processed differently. And we're looking at how does it change metabolomic patterns? How does it change the microbiome? How does it change some other things that we're looking at? And at the same time, we're running samples. We're running samples looking at clinical disease states too. So dogs with lymphoma, cats with chronic kidney disease, things like that. We have been involved with the Morris Animal Foundation, the Golden Retriever Lifetime Study. We actually went through all of their diet information for them and sort of cleaned it up and then gave them our opinion on the process part of it. And so we are in the works of getting samples to look at different age golden retrievers that are healthy, obese golden versus non-obese, lymphoma goldens versus non-lymphoma, maybe goldens with cardiac disease or not cardiac disease, things like that. We are working again with people at different places looking at what are called advanced glycation end products, which are end products of where protein and carbohydrates sort of mix under heat and water.
And usually we don't like those. Is that kind of your position, or what do you think about those? If you call them ages,
actually, we like them a lot because that's what gives food its flavor, right? I mean, advanced glycation end products are like if you grill a steak, the grill marks are give it more flavor. Caramelized onions.
I'm not sure that
right?
what we taste and what we should have are quite the same.
Right, the problem is that it's like anything. Too much is too much, and everything in moderation. So in humans, this is there are thousands upon thousands of articles that come out now every year on this. And the ones that have looked at associations with high levels of advanced glycation end products, either circulating in their urine or what they eat or any combination thereof, if you, depending on the study, eat like 10 to 15% of your diet that's high in advanced glycation products, your all-cause mortality goes up, like like 1.4 to 2 times if you don't eat as much. it increases your risk for cardiometabolic syndrome, chronic kidney disease, osteoarthritis, non-alcoholic fatty liver, things like that, neurodegenerative disorders. I mean, it's just everything. And what was found in at least a doctoral student's dissertation out of Europe, Van Rooyen, is that when you look at dog and cat foods, dog foods, and she measured it in foods, and then she compared it with if a dog, dog of a certain weight was eating this diet, how much would they consume? And then she normalized it to how much would a human eating a Western diet eat relative to a dog on a metabolic body weight basis. So it was a very clever thing to say dogs and humans aren't the same, but normalize it.
That denominator, right?
Yeah, and so it turns out that cats consume 42 times the amount of AGEs than humans do, and dogs 132 times the amount of AGEs. And then when you take a step back on that, and canned foods are worse than dry foods, when you take a step back on that, you go, so what are the diseases, again, associated with eating too much AGEs? Diabetes mellitus, skin disease, inflammatory bowel disease, chronic kidney disease, osteoarthritis, pancreas disease, liver disease, cognitive dysfunction, neurodegenerative disease. And you go, those are what we see a lot in our older dogs and cats. Now, the question is, does the processing have a role in this or not? And I mean, who knows? I mean, the answer is we don't know. We can only speculate, but we're starting to look at that now. And we showed that dogs that eat canned foods have more AGEs in their body than circulating than dogs who eat dry food, who have more than air dry food, who have more than just a raw diet, a minimally processed diet, where we use a pediococcus, a bacterial organism, to help with infectious disease. So those are the things that are very interesting to me. And we're trying to run disease states at the same time we're looking at controlled studies to then come back and say, well, if the disease state is associated with high AGEs, maybe now if we feed a diet that lowers it, would that have a benefit? That's where we're at.
That's very, very interesting. And sort of, if I could summarize what you're telling me is it's not just what you eat, but how it was prepared before you eat it that really, really we need to think about.
And I just want to state this. That isn't saying that dog and cat food's bad, right? I'm not saying that. I'm just saying that we don't know what the association might be. We don't even know if there's an association right now. And there are ways to modify that if there is an association. It doesn't even have to be cause and effect.
Yeah. Well, thank you for that correction. Not a correction, for that clarification, because one might go out and say, well, then I just want to stop ages intake, and that wouldn't be what you're suggesting. I understand that. So, but is there I asked you for looking over the horizon, so we look over the horizon, we say, oh, here's an area, right?
Yeah, there's an area, and you get a lot of people involved with it. And again, it's a group approach with residents and doctoral students and collaborators and pet owners and funding agencies and the industry, and you just keep building on things. And, for me, what's over the horizon is to continue to do this for at least some period of time, and then leave it for someone. You always want to train the person who's going to take your place and make sure they're better than you are. And so hopefully leaving it to somebody who's better, smarter, and than I am, and just continue on, that it's worthwhile.
Well, thank you. And, I obviously have felt the same way, and laying that foundation is certainly part of what our age desires, that foundation strong to build on. And, I sort of joke and tell people, that at least 10% of what I say is wrong. I just don't know which one that is. Right.
That is true. At least 10% is wrong. It's funny. I did I was teaching in a class, and at the end I always do like a little multiple choice quiz just to sort of make sure they got what I wanted them to get out of the lecture. And the residents wanted to come and listen. So the residents came in and listened. And at the very end, they said, that was really good. I learned a lot. And then one of them said, we don't know how you tell you this, but one of your questions at the end was wrong. And I went, which one? And they went, well, the one about such and such. And I pulled it up and went, I put the wrong drug down. Like, why didn't you stop me and tell me? He goes, well, we didn't want to embarrass you. I go, you're not going to embarrass me. Now I have to go through the entire class and say, I was stupid because I had made this slide wrong. Like, in the moment, you got to tell me. So like, yeah, at least 10%'s wrong.
Yeah. Well, Dr. Bartges, thank you so much. I just enjoyed having this interaction time. Thank you for it. Maybe we get a chance to do it again, dive a little deeper, but boy, today was fun. It was a good one.
Yeah, it just shows that you can be a jack of all trades and a master of none. I've dabbled in a lot of things. I'm not sure I'm a master of any of it, but it's been a lot of fun. Like Jimmy Buffett saying, I've had a good life all the way. So I got no complaints. And it was fun. Thank you for inviting me, and maybe we'll be back.
I hope we can. So thanks again. Good to see you.